and I think in the medical community generally, I think they could begin to use hospice as a model for how that can happen. And we're trying to get that more across to what we call palliative care, so that you kind of come in and further upstream. Because people get very frightened. They hear the word hospice and they think that's the death sentence. Hospice equals death, you know.
And they may think it hastens death.
Sure. You sign up for hospice one day, the next day you're dead. And truth be known, I've known this anecdotally for a long time, and research is now bearing me out, that people actually end up living longer.
Welcome to the Daily Dose, Empowering Seniors Daily Dose. I'm Catherine Ambrose, and I'm sitting here with Father Tom Welk, and we're going to visit about end-of-life issues and ethics and hospice. So welcome, Father Tom.
Glad to be here. Thank you for inviting me.
So tell us, first of all, what is the origin of hospice? How did modern hospice come about?
To answer that question, I'm sorry if I'm going to be lengthy on that. It's been a saying around for a long, long time about the role of medicine. And it puts it in a threefold way: cure sometimes, relieve often, but to comfort always. And if you're looking at those three and you put yourself back, say, in 1900, and so you're the famous Dr. Ambrose, I come to you in a life-threatening situation, what could you do to keep death at bay at 1900?
Yeah, probably not much.
And again, if you had said nothing at all, you would have answered eloquently. There really was not much, but what you could do that was very helpful to me was be there to support me in what I call the dying role. Support me when I have a lot of living to do yet and take care of a lot of unfinished business. What I alluded to earlier about this was often counterproductive in terms of physical intervention. Say if you had posited that it wasn't evil spirits that caused me to be diseased, then there were two words. But the exorcism didn't work, and I said, my head hurts so bad it's ready to bust open. So now you're the physician, so how are you going to release those evil spirits?
Maybe cut into it.
They would use a fancy procedure, drill a hole called trephination. Do you think that helped me any?
Probably not.
But what you did do that would help me is to be there with me in a lot of supportive ways, comfort always. And that's really what medicine did very well. So the history of hospice really spans the history of medicine. It's only when we were able, with the advent of modern medicine, which was with penicillin in 1942, that's only the tip of the iceberg. We have so many, almost an endless array of medical interventions, that medicine sort of flipped its role. Today, medicine is used primarily as a way to fix something, whether it's, again, disease caused by, excuse me, the animalcula, as the Latin word puts it, the little beasties, the little miniature monsters we call bacteria or germs. So penicillin takes care of that. But at the same time, when you're looking at only fixing, you have to keep in mind what's the mortality rate for every generation. Eventually, we're going to be unfixable. Mortality is 100%. Then what do we do with medicine? We have to flip to the role of comforting people.
And comforting their families.
It's a very good point in terms of mainline medicine. Say you're, again, my physician. Who would be your client? The patient. When it comes to a program like hospice, the client isn't only the individual identified on a list, the patient list. The client is also the patient and the family. And many times in a good hospice program, there will be more time, energy expended on taking care of that patient's loved ones than actually just the patient himself or herself. So that's very important for the comfort of the patient to know that loved ones' needs are being addressed. And so we talk about hospice in a fourfold way. Providing physical comfort, that would be keeping pain under control and symptoms managed. Very, very important, obviously. But that's not how I am defined, basically, only by my physicalness, my body. I'm much more than that. So is every human being. We are also psychosocial, spiritual. And so we need to make sure that my emotional needs are addressed, my fear of the unknown. We need to address my loved ones because we're so intimately tied in with one another. And if I feel that my loved ones' needs are not being taken care of, then I'm not taken care of either. And then I think the fourth one, we often confuse spirituality with just being religious or pious. You know, I'm a really pious person, you can tell. But spirituality really talks more to that sense of meaning or purpose every human being needs to have. Mm-hmm. And when you're looking at death on the surface, it seems to be the most meaningless, purposeless thing we have to go through, annihilation. But if you see beyond death and find meaning in death as now transcending the body and moving into a further, deeper existence, then that brings a lot of peace too.
It does. And for families, it's such a hard time. Sometimes when people have a sudden death, that's quite different than someone that's having a slow decline from illness.
Sure. When we're looking at the question of how death occurs, we also need to weave in the dying role. I said it's a very meaningful, I call it a very holy, sacred part of life journey, when there's a lot of living still needing to be engaged in, and maybe a lot of unfinished business that has to be addressed. Mm-hmm. This was brought home to me so starkly with one patient. As I had my initial visit with the patient and I walked into her room, the first thing out of this patient's mouth were the words, "Thank God for cancer." So how would you take that if you're walking in? It seems like something weird for someone to say. Why would you say thank God for cancer? Mm-hmm. So I'll put you on the spot a little bit. What would be there?
Well, the first thing I would think is, does she have a death wish? I don't understand.
Sure.
So you have to be curious.
And so I had to keep my mouth shut too, because I was going into a lot of different things, scenarios that anybody can envision. So I let it unfold. Find out that this woman had a lot of issues that needed to be addressed, particularly within family. Call it whatever, but a lot of dysfunction. Mm-hmm. And she wanted that unfinished business to be taken care of. So myself and the social worker, joining hands, we enabled her, brought in those family members, those loved ones. They had their talk, they resolved their issues, they had reconciliation. And you can pretty well guess, after all of this had happened, what happened in short order?
She died.
She died, absolutely, right. But this is so important when you're looking at, say here I am going along on a pretty even keel, mm-hmm. and I run into a precipitous situation, literally, accident, heart attack. You don't have the time and the opportunity to address that. Mm-hmm. And it leaves also quite a void for those near and dear people in that person's life. But when you're getting along here and all of a sudden you have a diagnosis of a terminal illness, say it's cancer, like this woman's situation, it's not precipitous, but here's the even keel, and here's the decline, here's death. Mm-hmm. So you've got a lot of time and a lot of opportunity to take care of those issues that really need to be addressed.
Mm-hmm. And not left things unsaid.
Right.
Because people are haunted for the rest of their lives, for decades often, by that unfinished business.
It's been shown through a lot of research on the follow-up, the grief, the bereavement that results from having to say goodbye to someone near and dear, that people generally have a much healthier way of healing from that loss than if it had happened suddenly and precipitously. It now offers them an opportunity to put their lives together, because we are all intricately interconnected. You know, no one of us lives life in totally rugged, individually sort of way. We need each other to find meaning and purpose for ourselves. And that is so very, very important for human beings, having a sense of meaning or purpose, what I call spirituality. Mm-hmm. I can give you a couple of quotes if you're interested. Absolutely. Mark Twain, one of my favorite authors, who asked the question, what are the two most important days in the life journey of any individual? So what would that be?
Well, it could be birth and death.
Which where people go most invariably. Two most important days, birth and death. Mark Twain will agree that one of the most important days is the day we're born. But he says the second most important day is the day we figure out why we were born. I think the saddest epitaph on any tombstone would be, here lies an individual who left this world without knowing why they entered it. That would be a sad epitaph to have on your tombstone. But even when it comes to finding meaning or purpose, where Mark Twain also goes, is that talking about tombstones, so almost invariably, among other things, on a tombstone you'll have three things. the birth date, the death date, and what do you have in between?
The dash.
The dash. So that's what's important. How do we live that dash? How do we live that journey? Let's hope it's not a 100-yard dash, but you know what I'm talking about here. So what makes it meaningful? What makes it purposeful for us? And I think interconnectedness definitely has to be there. And for us to say, you know, I don't need, you know, death is a totally individual thing and it should be on my terms, that's nonsense. We don't really have death not affecting just, it doesn't just affect me when I die, it also affects those who are near and dear in my life. Mm-hmm. So family, again, very important in terms of the unit of care.
Yeah, that, going dark here, that almost makes me think about suicide and the pain that is left behind. It's so sad.
Yeah.
And even young children that have to live with maybe a parent that has done that. It's something that shadows their whole life.
That's where suicide, when you're weaving it there, whether it's called assisted suicide or euthanasia, but what I like generally call just hastening death, I think we need to take a very serious look at that phenomenon that you have raised here. And I think you're right on target. I'd like to see more research done on, so you have someone who goes the route of hastening their death. What are the long-term consequences or repercussions? How does that affect, for better or worse, I suspect for worse, the journey as it continues for those loved ones? I think often they may have a very difficult time. And we see it in suicide. It is so devastating when you take a look at it for people. So I think the verdict is still out on whether that's really something that we ought to really push hard.
So I know you're very involved in medical ethics. Could you tell us a little bit about that, what that means?
When you're looking at what I said earlier in terms of the history of medicine, when you were looking at it, say, whether you're going to do or not do in 1900, you could very easily say to the physician or the medical professional, Doc, do anything and everything that is possible. But what did you have in 1900 if you're this world-renowned physician?
Right, very limited.
Very limited. So you didn't have the painful wrestling to go through, do I or do I not go through this? Well, we're no longer at that point. When you have now someone confronted with a difficult situation, say a particularly life-threatening, there's almost an unlimited way of medical interventions. There's an endless array going on. When do you decide, or how do you decide when enough is enough? That's where now medical ethics has come into the play. It is now a very systematic way of sorting out when is enough, or why would I not, or why would I engage in this medical intervention? So to set up a scenario that might illustrate this point, so here I'm the typical male who probably doesn't make easily medical appointments, and I'm not going to tell you how long it's been since I've seen a physician. So I finally make an appointment, say I'm going to use the cameraman with Dr. Ben. So why would I come to make an appointment with Dr. Ben? Because I'm really doing well, or because I'm doing poorly?
Poorly.
Poorly. And so what do I want this world-famous doc, next to you, the next world-famous doc, what do I want him to do? I want him to make things
better.
Worse.
Okay.
That's nonsense, isn't it? These principles are what are called in the legalese Latin, prima facie. They're self-evident principles. So it ought to be very self-evident that what we want to have happen from medical interventions is make things better. What we call beneficence. We want a benefit out of the intervention. But here's the other thing. There is no medical intervention that doesn't have an up and a downside, a benefit and a burden. There's no question about that. So I'm going to have to weigh, sometimes very painfully, am I going to benefit more from this, or is this going to be a greater burden? If it's going to be a greater burden, then it's unethical to engage in that. And then the second most important principle is, who decides Tom's well-being? Who decides the patient's well-being? Is it Dr. Ben? Or is it Tom? That's where the next important ethical principle comes in, what we call autonomy. So that we now will need the patient to get all the information necessary to determine, okay, doc, what's all the information? What's going to do to me? What can I expect in terms of the outcome? Then I'm the one who makes the decision whether or not that's going to happen. But what if Tom has lost his decisional capacity? And don't say you've already reached that point. That wouldn't be nice. But what if a patient, which happens more frequently now than it did in 1900, you were a female child born in 1900, to what age could you expect to live?
I don't know.
48.
Okay, I was going to guess 53 or.
Pretty close. You're a female child born in 2020, to what age can you expect to live? They just flipped the 48, I heard this on NPR program, to 84.
Okay.
Were you likely to lose decisional capacity at 48? Not likely. How about at 84?
Could.
Much more likely. So here now we still have to have a decision regarding do we or do we not when it's enough enough. So here Tom is 84. Men don't live that long, but say I have. And yet he's lost decisional capacity. He's bonkers. And then Dr. Ben has to make a decision whether or not to do the intervention. Who tells Dr. Ben to do or not to do? Tom isn't able to. That's where we go the route, where we now have legal ways to determine someone else now, we call advanced directives. I can name someone else who will make that legal decision. They're telling the medical community yes or no. So those are very important, since you brought up the question of ethics. Very important for any and all of us to engage in making sure we have those legal documents. And I'm not going to make a survey here with a bunch of us gathered here, who has and who does not. I can assure you I have filled out my advance directives, my living will, my power of attorney, so that I have someone designated to make those decisions for me when I'm not capable.
And what about surviving family members that might have regrets that they didn't try enough or that they tried too much? What would you say to them?
And where that comes up most often, the issue I deal with on a very regular basis, there's hardly a week goes by where I am not asked to give some kind of, or asked to consult with regard to what is called medically assisted nutrition hydration. And you've got someone who's incapable of providing for themselves nutrition hydration with eating and drinking. Now there's a decision of doing the medical intervention we call medically assisted nutrition hydration. A lot of people call it feeding tube. I don't like that because it has both a moral and an emotional overlay. You would be considered very culpable if you didn't feed someone like an infant who is incapable of going out and getting the food, but once you get it to their mouth, they eat and drink. That's vastly different from someone who's compromised in their ability to eat and drink. You take someone like Terry Schiavo, if you recall that case. You could have put a ton of food in front of her mouth. She was incapable of engaging in that activity called eating and drinking. She was on a medical intervention. And this is where people put such a guilt trip on themselves. So they had a loved one who was incapable or didn't want to because of a terminal illness, the body's shutting down. And so if you don't eat and drink, what's going to happen? If you deny someone eating and drinking who's capable, what are you doing to them?
Well, starving them.
You're starving them to death. And that's where they put that overlay on themselves. I have starved my loved one to death. And for them to have it now unfolded in a way that says, no, there was an underlying condition allowed death to occur. Hospice, by the way, is very, very clear in terms of this question of hastening death. Our position is very, very clear. We're not going to engage in hastening someone's death by introducing someone that will cause their death rather than the underlying condition, whether that be a lethal injection or whatever. So we're not going to do that. But secondly, we're also not going to simply delay the prying process. So we're going to be there. If someone is capable of eating and drinking and they want to, we're going to strongly encourage that. But if for someone who isn't capable or they don't want to because the body can't use the food or the liquid, that's a natural way of letting go. I can go into more detail on that if you want. I don't know if you want to engage in that some more or not.
Well, sure, because in some of my continuing education, I've heard that that often is part of the natural process of
Our
that.
bodies have a natural wisdom in knowing how to shut down. And a body that doesn't need fuel, I'll use it that way, you don't want to push it into them. You take the normal way of getting liquids into our system is drinking. Now, someone is not drinking anymore. And by the way, medically assisted nutrition hydration in its proper place is very beneficial, but not in the dying role. I will say that categorically. And you're actually, if you talk about hospice being involved in comfort, in that fourfold way I talked about earlier, if you start pushing things, you're interfering with that wisdom. So here someone doesn't want to drink anymore. And we can get liquids in there. Just say, use the IV, one of the simpler ones. I've actually seen people, because they couldn't move it, their skin burst from not being able to do that. So you start looking at, you and I take with a normally functioning body, all of us here, in a hot day like today, how do we eliminate the liquids we take in? The very obvious one, urination. Second one, perspiration. The third one,
exhaling.
most people don't, they just struggle with that. So you go on a mirror that's cold, you put your breath on there, you'll see a lot of condensation on that. So you've got someone whose kidneys are shut down, their lungs aren't functioning right, and they also are not active. So those three are eliminated. Where does that liquid go? Settles in the lungs, and liquid water in the lungs causes drowning. Those are not comfort measures.
Right.
Most of the time when people who are in the dying role talk about being thirsty, they really are talking about having need of good oral care. And so you get someone like Tyson, the nurse. If he's going to be a good nurse, how will he alleviate good oral care? So with chips and salve and those kind of things. The same way with food. I'm a farm boy. And if we didn't run the tractor, we weren't going to keep pouring fuel in there. It would be nonsense. It would just be all over the ground, right? So our bodies are like a machine. If I'm active, I need fuel. But what if my body's not able to use that fuel? What happens to warm food out in the warm environment?
Yeah, it goes bad.
Goes bad. It rots, to use it very deliberately that way. So you have someone who can ingest food and it gets into the stomach that's not working.
That makes sense.
That makes sense. And that moist, warm environment makes them terribly uncomfortable. So pushing that stuff with the medical interventions is not a comfort measure. Can I say it more categorically? That is an ethical issue. I would even go as far as to tell you that to push medically assisted nutrition hydration when it doesn't provide a benefit is actually unethical. It's the wrong thing to do, both from a physiological point of view and from a moral, ethical point of view.
That completely makes sense. I'm just thinking about families that might have some hope that something might change. Maybe not a long period of time, but maybe a little bit of a recovery where they can spend a little more quality time together.
And I never, ever want to come across as dashing someone's hope. But we have to be sure that we define hope in a way that makes sense. I think too often in the medical community, what we have coming across when you say, well, we don't want to shatter hope for this person. And then so we start doing what? So Dr. Ben knows that Tom's not going to benefit from this intervention. But because he doesn't want to shatter hope, he starts promising me things that he can fulfill.
Or
Do any of us
options.
offering options that cannot ever provide a benefit? Do any of us like to be lied to?
No.
So why would we want to lie to someone in those?
Very touchy situation, because sometimes you wish doctors could just say it and be more direct, but I know that there's so many things that might cause them
Yeah,
to
a
be
lot
very
of
cautious.
dynamics. My heart goes out to physicians who really want to, but they really struggle, because the kind of things that probably they didn't get a lot of training on in medical school was what I call relational skills. And it does take, I never want to come across as advocating with regard to this moving from the sick to the dying role, kind of using the sledgehammer approach. You've got to use a lot of nuance in a lot of different ways. You need to read where people are coming from. I have found pretty quickly, as I been doing this work for many, many years, that pushing people is counterproductive. The more I push someone, the more someone pushes me, the more I will dig in my heels.
Right.
Absolutely.
When my father passed away, I think that there were just so many reasons why we ultimately decided it wasn't right to keep him on a ventilator. But still, we still questioned ourselves whether we could have had it last a little longer.
Yeah.
We really didn't have hospice. This was in another state, and we were told hospice, but now we know it really wasn't hospice service like what you're talking about. And it's hard to live with some of the decisions that you make, especially when things
very
don't
difficult.
go well. It's kind of like having a birth plan. Sometimes couples or expectant mothers have a birth plan and they just think it's going to be exactly the way they've defined it.
Good luck.
And so I was thinking about that this morning, the same thing in death, that you have to just let go of the things that can't second guess yourself.
And that movement is very, very difficult. Again, I don't want to minimize that this is, yeah, sure. What I call moving from the sick to the dying role, where in the sick role you have expectation that things are going to be fixed, we'll get more time, versus in the dying role, you're in the last part of life's journey. And when you posit it that way, going back again to 1900, that movement from the sick to the dying role in 1900, was it easy or difficult to say, Dr. Ben's going to fix it, or am I going to say, no, he can't do anything anyway? So was it easy or difficult in 1900 to move, just from the medical perspective, sick to the dying role?
Probably much easier.
Much easier, because there was nothing anyway. How about in 2020?
It's very challenging because
very challenging.
Unlimited options are coming.
Endless array. There's always something more, always something more. And I've had many a physician tell me that word for word. When it comes to treating this person for this, there's always something more we can do. Yeah, sure, you've got the protocols there, but at the same time, you have to ask yourself that basic ethical question of, to what end or purpose? Can you realistically expect that these medical interventions will provide a benefit?
That reminds me, what I was going to share with you about my father's death is that the hospital seemed willing to do just any next step until my mother said that's enough. And then you could almost see the relief on the physician's face. And then they were ready to get back to kind of reality.
Sure, reality, and also maintaining their own integrity, both personal and professional.
They needed her to make that decision.
Sure, yeah. And so they were probably relieved that finally I don't have to do something I consider futile. None of us like to engage in futility.
Because at that point it really was more about the family than about the patient.
Yeah. The other thing that comes to mind as you're raising that question about the ventilator, what we call basic life support interventions. So you've got someone who's needing that medical intervention we call the respirator or the ventilator. And so you remove that and death occurs. What does it feel like or look like has happened? What, in terms of 1 minute the person's alive, you stop the intervention, they die. People will often say, did we cause the death? A lot of people go that route. I would tell them categorically, no, you simply allowed death to occur. They were on that basic medical intervention because something wasn't working. And so in the past, here we had the insult, whatever it was, the disease, and then very quickly death would occur. In 2020, here you've got the issue, and what did we put between the issue and death? The medical intervention. And in Terry Schiavo's case, we kept that intervention in place for 15 years. So once you stop the intervention, the medically assisted nutrition hydration, you have to backtrack to what caused her to be on that in the first place, which was for her what they call myocardial infarction, a massive heart attack, that kept oxygen to her brain for documented over 10 minutes, which would cause massive brain damage. So you have to go backwards and determine we allowed that to occur finally.
Well, and then we hear these stories that give hope, maybe oftentimes unrealistic hope, about the, one person that woke up after 15
Yeah,
years.
and here you go into a clinical question. But there are many ways which you can have someone be unresponsive or unconscious, including being asleep or having just somebody socking upside the head, or you get into a very serious situation like a car accident or near drownings, and then you get comas and locked-in state and permanent vegetative state. So those are so very important in terms of I'm going to have to rely on a neurologist to make those determinations. A good friend of mine, I shouldn't say good friend, I knew him quite well, Ron Cranford, who actually went from Hennepin County in Minnesota to Florida, and they were asking him to diagnose what's going on with Terry Schiavo. And I had a conversation with him later, and he said it was one of the more clear-cut diagnoses he had to make. There was no way that that woman had any upper brain functioning left. All that was left was the brainstem, which has what we call the automatic, the autonomic, including breathing and all of those kind of things. But any conscious, voluntary activity, absolutely no. Well, let me add one more thing here.
Sure.
When you're looking at what defines life for us, yeah, we have a body, but we are much more than our physicalness. We are defined much more so by our psychosocial spiritual functioning. And when we talk about people needing some basic life support interventions, in many instances, are we really supporting life in the deeper definition? Or are we simply supporting a body? So why don't we change it rather than calling it life support? This person is simply on body support. And is death the worst thing that can happen to us? We will exhaust curing. We'll never exhaust healing. And when we get to that point where our bodies are so compromised, they're incapable of now serving us in our deeper function, the psychosocial spiritual, then what must we do with our bodies? Let them go. And we call that letting go of the body death. So when you think about it, death is really the ultimate source of healing for all of us. One other quick patient story. I was involved in providing pastoral care for this delightful woman, moved from out of state, lived with her daughter in a nearby community here, and so she didn't want to connect with a parish, a church, a congregation. So I would provide visits and took care of that and really got pretty close to her. As she was actively dying, I provided a ritual, what I call commendation, a healing ritual, praying someone home to heaven. And so for the patient in her daughter's home, her granddaughter came from Texas and brought her daughter. So 4 generations of women. So after I provided the service, I considered it not wholly sacred ground. I wanted to stay apart. This is family time. And the daughter, distraught, saying goodbye to mom, which she needed to. But the patient's granddaughter in turn said to her mom, "Mom, it's okay. Grandma's spirit has outgrown her body. It's time for Grandma to let her body go." You know, I struggle for words over and over again to tell people, about the transition and difficult as it is, goodbyes and so on. But I don't think I can ever find words that sum up so well what this young lady said. Grandma's spirit has outgrown her body. Time for Grandma to let her body go. Time for who Grandma is to move beyond that.